was a 68-year-old female, non-hypertensive. She was symptomatic since 2 months, presented with complaints of low-grade fever on and off, decreased appetite and weight loss, generalized itching all over the body, abdominal distension. She had a history of recent hemiarthroplasty done 1.5 months ago. On examination, pallor was present, icterus was present. There was no edema, no lymphadenopathy. Her abdominal examination revealed soft, non-tender. There was hepatosplenomegaly, and there was a suspicion of free fluid. So differentials based on the initial history and physical examination findings were likely a chronic liver disease with a decompensation, can be malignancy, can be tuberculosis, autoimmune condition, but which was less likely. Any other differentials which we can think of? Then the initial laboratory workup was done, which revealed the CBC showed biocytopenia with a hemoglobin of 6.1 milligram per deciliter and platelets counts of 1,53,000. LFT was deranged with a total bilirubin of 2.96 and alkaline phosphatase of 377, which was probably a cholestatic pattern. The profound finding which we found was the deranged PT-INR and APTT. INR was 8.38, prothrombin time was 72.1 second, APTT was 54.4 second. Viral marker were negative. CRP was 83, PCT was 0.15, blood culture was negative. We also suspected autoimmune conditions, so we did ANA by immunofluorescence, which was negative, and anti-smooth muscle antibody, which was also negative. Initial sonography abdomen was done, which showed liver was normal in size and echo texture. There was no intrahepatic biliary radical dilatation, no focal lesion in the liver. GB calculus was present, but there was no evidence of cholecystitis. Mild spleen was enlarged, no ascites. So all these findings made chronic liver disease the less likely the cause for the patient's condition. So we probed further. To summarize the case, my patient was an elderly female with a history of fever, weight loss, generalized itching. On laboratory parameters, she had biocytopenia, deranged LFT, increased PT-INR and increased APTT, and a USG finding of splenomegaly. So what next? How do we approach a patient with a prolonged PT and both APTT? So there are a few causes which can be pre-analytical causes, which include the heparin contamination, any underfilling of the tube. There can be drugs, the direct or indirect inhibitory drugs, or the supratherapeutic warfarin effect. There can be inhibitors. There are non-specific and specific. The non-specific are the lupus anticoagulant, that is the antiphospholipid antibodies, and specific inhibitors to coagulation pathway, which are rare. And then can be decreased factor synthesis also. So this can be congenital and this can be acquired, or the acquired causes, which can include the impaired production or due to some liver disease or vitamin K deficiency. Or this can be due to factor consumption or binding, like in massive hemorrhage, DIC, or factor 10 deficiency associated with systemic amyloidosis. So patient was advised mixing studies. So mixing studies is basically to differentiate between the clotting factor deficiency and the presence of inhibitors of the coagulation pathway. In this, the patient plasma is mixed with the normal plasma, and then we serially measured the APTT. So in our case, the APTT was still not corrected. So if it gets corrected, then it suggests that there is a deficiency of the clotting factor. But in our case, it was still not corrected. That means there were some inhibitors of the coagulation pathway, which can be factor VIII inhibitor, antiphospholipid antibodies like lupus anticoagulant, and common pathway inhibitors. So the following detailed workup was done, which revealed lupus anticoagulant was present, anticardiolipin IgM was present, beta-2-glycoprotein was negative. These were the apply antibodies workup which was done. And for the anemia part, LDH was raised, reticulocytes were also elevated, and Derrick's Coombe test was positive, which was 2+. So it suggested a component of autoimmune hemolytic anemia. So basically, our patient did not have any clinical history of thromboembolic phenomena, which was suggestive of either Appler syndrome or either any SLE features, but yet she was having a component of autoimmune hemolytic anemia. So all these pictures were fitting into a hematolymphoid malignancies, which can cause elevated Appler antibodies and autoimmune hemolytic anemia in an elderly female. And to probe further, we did a PET CT, which was done on day 6, which showed splenomegaly with diffuse increased metabolism along the metabolically active multiple lymph nodes in the abdomen. The patient was to be prepared for lymph node biopsy of the abdomen, but due to deranged coagulation studies, it could not be performed, and instead she underwent bone marrow aspiration and biopsy, which revealed aparticulate marrow with a 2:1 ME ratio. Biopsy revealed hypercellular marrow for age with nodules of small to medium-sized lymphocytes with positive CD20, CD79A. Thus, the diagnosis of splenic marginal zone lymphoma was favored over diffuse large B-cell lymphoma in view of hepatosplenomegaly, lupus anticoagulant antibodies, and multiple lymphadenopathy. Chronic leukemia flow cytometry analysis showed approximately 3% large abnormal B cells consistent with bone marrow involvement by a B-cell non-Hodgkin lymphoma. So on day 10, patient was started on a chemotherapy. We started the patient on rituximab and bendamustine. She received injection romiplastin also, which was in view of thrombocytopenia. She was also started on steroids, methylprednisolone, 500 milligram for 3 days in view of autoimmune antibodies positive. She had also received PRBC and SDP intermittently. So discharge and follow-up. She was discharged on 15 days on oral steroids, tablet prednisolone. Her symptoms showed significant improvement. Post-discharge, she has received 3 cycles of injection rituximab as maintenance chemotherapy. Follow-up PET-CT was done on 6/10/2023, which showed complete regression of the lymph nodes with significant regression of the spleen. Our LFT, PTI, and our APTT also improved significantly in the due course of treatment. So, splenic marginal zone lymphoma, it is an uncommon type of B-cell non-Hodgkin lymphoma and usually present in adults with splenomegaly and lymphocytosis and cytopenias. The median age at diagnosis is 65 years age, and there can be no sex predominance. And unlike most other non-Hodgkin lymphoma, this is varies by lymphadenopathy, involvement of extralymphatic organs, systemic B symptoms, and elevated LDH, which is uncommon. So there are few autoimmune findings in this patient splenic marginal zone lymphoma in 20% of the patient, which can include autoimmune hemolytic anemia, immune thrombocytopenia, cold agglutinin disease, antiphospholipid antibodies, acquired von Willebrand disease, or angioedema as a result of acquired C1 esterase inhibitor deficiency. In our patient, we had autoimmune hemolytic anemia and antiphospholipid antibodies positive. So for diagnosis, we require a CBC with a differential count, histologic review of either the bone marrow aspiration biopsy or spleen if it is available. And then we do the immunophenotypic analysis of the tumor cells, which show expression of the surface immunoglobulin IgM, IgD, B-cell antigen like CD19, 20, 22, and BCL2. And CD5 is usually negative, which helps in differentiate from the other non-Hodgkin lymphoma, but it can be positive in minor subset of cases. So treatment, it is usually we start the patient on usually there is association of hepatitis C. So if the patient is positive for hepatitis C, then we first treat the patient with antiviral and then we progress. If the patient is negative for hepatitis C, or if the patient has symptoms of splenomegaly, then we what are the indications for treatment, which are the local symptoms related to splenomegaly and or progressive cytopenias due to extensive bone marrow infiltration or hypersplenism. Then the option available for treatment are the rituximab or splenectomy, or we can observe if the patient is mild symptoms or if there are any autoimmune complication, we can treat that. And after the progression, we do the sequential systemic therapies. So there are only few reported cases of splenic marginal zone lymphoma with autoimmune antibodies positive in the literature. So to conclude, prolonged PT and APTT without clinical evidence of coagulopathy should prompt investigation for coagulation pathway inhibitors like lupus anticoagulant. Bendamustine rituximab is a reasonable first-line therapy for patients with marginal zone lymphoma positive autoantibodies. Intermediate or prophylactic dosing anticoagulant should be considered during initial therapy for cancer patients with positive antiphospholipid antibodies to prevent thromboembolic events. Thank you.
It was quite an interesting case where the initial diagnosis was, of course, we thought of CLD, but gradually things did not fit into CLD. The ultrasound was not suggestive. She was quite coagulopathic, but she was not bleeding. So we did a mixing study, and mixing study showed presence of APLA antibodies, like in the lupus anticoagulant initially, and then confirmed as presence of APLA antibodies. We did imaging, which initially did not reveal much at the ultrasound, but gradually then we did, because of bicytopenia, presence of autoantibodies, Coombs being positive. We did PET-CT scan. The PET-CT showed presence of abdominal lymph nodes. But we were stuck at that point because her platelet counts were rapidly falling. So she came with a platelet count up, I think, slightly low, 110 or something. Then it gradually fell down in over a span of next 5 to 7 days, and it had come to as low as 5,000-6,000. And she was quite coagulopathic, PT, PDT both being prolonged. So we were not able to get the lymph node biopsies from the abdomen. So did a bone marrow biopsy, and the bone marrow flow cytometry showed just 3% abnormal cells. So we had to take decision based on that 3% abnormal cells to go ahead and give a chemotherapy and stamper the diagnosis. So which itself is a quite rare diagnosis, splenic marginal zone lymphoma. And it was associated with this kind of autoimmune manifestations. Her counts were rapidly falling. She was coagulopathic, and anytime she could have bled. So then with that risk and counseling the family, we started our own treatment. We started our basically on steroids along with bendamustine rituximab. But just after the first dose of bendamustine, I think the platelet count came down to 2,000 or 1,000. So we did not give further bendamustine. We just treated her with rituximab. And she started showing immediate improvement. So she was having intractable pruritus. The pruritus improved, the platelet counts, the coagulopathy, everything kind of improved. So the plan was we give her 4 courses of weekly rituximab, repeat the PET-CT scan. And after about 6 weeks, all the lymph nodes and the spleen side had come to normal, her blood counts returned to normal, coagulopathy completely corrected. So now, in fact, today she is taking her 3rd maintenance rituximab, and just another rituximab she will take, and that's her treatment will be completed. She's completely asymptomatic and just coming 2-monthly follow-up now. Madam, so in this splenic marginal zone lymphoma, we give weekly for 4, and then thereafter every 2 months for 4 more. Total 8.
Thanks, Manish. Thank you. So we move on to the next presenter. This is Dr. Neeraj Shetty. He is a dynamic interventional radiologist, and he present vascular interventions in GI. Neeraj?
Yes, ma'am.
Hi, thank you for the introduction, ma'am. So my name is Dr. Neeraj. I'm an intervention radiologist, and my topic for today is vascular interventions in GI. So before I speak about my topic, I want to briefly talk about intervention radiology and the history behind it. So what is intervention radiology? It's a specialty that involves use of imaging like ultrasound, CT, MRI, fluoroscopy to do procedures, to do more than diagnosis, like diagnosis plus treatment. So coming to a brief history, how it all started, all this started because of these two guys. The person on the right his name is Dr. Charles Theodore Dotter, and the person on the left is Andreas Roland. Okay, so Dr. Charles Dotter is called the father of intervention radiology. So how it all started? It started on January the 16th, 1964. When a 82-year-old female presented with the lower limb ischemia and gangrene. So he opened up her superficial femoral artery by using a wire and a Teflon catheter, but just pre-dilating it. So all this started because of him actually. And following this, Dr. Andreas Roland, who is a German radiologist, a physician, a cardiologist, who in Dr. Charles' footsteps, he started, he invented balloon angioplasty. He invented the balloon. He did a successful superficial femoral artery angioplasty, followed by a successful cardiac angioplasty. So all this started from them. So both are Nobel Prize nominees. And So a glimpse into the birth of intervention radiology would not be possible if I don't mention about the Seldinger technique. So it is through this technique we could minimally access the veins or the arteries by just using a needle, a wire, and a catheter. Okay, because of Dr. Seldinger, he's a Swiss radiologist. So so he comes from a family of uh, uh, precision making tools. His family was used to make precision making tools, and in the 1950s, he did this technique. So because of this, the invent or the advent of diagnostic angiography happened. Then after this, Dr. Stanley Bourne. So after daughter and used angiography to increase the blood flow in the occluded arteries, Dr. Stanley Bourne used them to stop the blood flow in patients with GI bleeding. So in the 1950s and the 60s, patients with GI bleeding faced a massive clinical dilemma because they had to be subjected to laparotomies, because then there were no flexible endoscopy or colonoscopy then. So Dr. Stanley Bourne, he's an American radiologist, along with Dr. Moray Osborne. He started contrast agents specifically into the arteries, and they did therapeutic therapy too. They started injecting vasopressin into the bleeders. So yes, so this is the history. And coming to my topic, and then later in the 70s, after the advent of stents and all, by Dr. Roshida and Dr. Rola Pinto, these are all the, now their names are on the lot of things have been discovered. They're like scientists who discovered how to assess the photosystemic shunt, how to treat portal hypertension, refractory ascites, and refractive varices. They invented TIPS, basically, transhepatic photosystemic shunt. Coming to my topics, vascular interventions in GI. So I'll be talking about embolization. So basically, embolization is entering the artery and blocking the artery, whether it be a liver-directed therapy for hepatocellular carcinoma, or whether treating a primary benign lesion like a large liver hemangioma or a renal angiomyolipoma. Depending upon the hemodynamic stability of the patient, embolization can be done for trauma-related liver injury, splenic injury, renal injuries, upper and lower GI bleeds. As it must, the patient with upper or lower GI bleed must be subjected to endoscopy. But if endoscopy doesn't find anything, or the preparation is not very well, then the patient is subjected to CT angiography to find the cause of bleeder. And then if we find something, the patient is subjected for intervention radiology to find the bleeder. Then vascular stenosis occlusion, like superior mesenteric artery stenosis or celiac artery stenosis, or the splanchnic system occlusion, like the SMV thrombosis or the portal vein thrombosis. So all these can lead to gut ischemia. So the patient can be subjected for a thrombectomy or a catheter-directed thrombolysis to overcome the occlusion. Okay, and portosystemic interventions for refractory ascites and refractive varices. We can do TIPS. There is something called a CRTO for fundal gastric varices, where we coil the gastric varices. Okay, and there is something called as TJLB. This is transjugular liver biopsy, which is done when percutaneous liver biopsies are contraindicated. So this coming to liver-directed therapy. So this is a gentleman who has a HBsAg-related HCC, and on evaluation, he has a 3 into 3 centimeter lesion in the left lobe of the liver, segment 2. There's an arterial phase. You can see over here, it's an arterially enhancing lesion, and in the portovenous phase, it is getting washed out. So it's evident that it's a HCC. So, and as you can see, it is a cirrhotic liver with the nodularity on the, so eventually this patient should be subjected to hepatectomy or a transplant. Okay, but this patient so could not be subjected to surgery due to because he had signs of portal hypertension. So there were chances of decompensation. So as a bridge to transplant, we took him up for TACE. So what is TACE? It is transarterial chemoembolization. So the image on the left is a digital subtraction angiography or a fluoroscopy image, where we have cannulated the segment 2 artery selectively, and we have injected a chemotherapeutic agent and a contrast agent. So chemotherapeutic agent, normally we inject something, doxorubicin, and the contrast agent is Lipidol. So, and after infusing this, as you can see over here, there is good deposition of the lesion with this Lipidol and doxorubicin combination. So this is one treatment which can be used as a bridge to transplant or a bridge to surgery. This is one more patient with the known case of HCC, a lesion in the right lobe with no signs of portal hypertension. He was subjected for a right hepatectomy, middle hepatic vein sparing hepatectomy. So what we do with this called as virtual hepatectomy, after CT scan, we do some post-processing and we find the future liver remnant. After the hepatectomy, how much liver will be left? Because if the liver is less, then the patient will be decompensated. In a cirrhotic liver, we take a cutoff of 40%. So when we did an FLR, it was 32%. So what we did, we treated this lesion by doing a TACE plus a portal vein embolization for the right lobe. As you can see over here, we have embolized the right lobe. These are the anterior and the posterior segments of the right lobe. We have embolized using glue and Lipidol. Glue is it's a medical grade Fevikwik what we use, and Lipidol is it's a lipid based contrast agent. So we have embolized this, and we have done TACE also. So eventually what will happen by blocking the portal vein, all the splanchnic circulation will be directed towards the left lobe. So this causes the hypertrophy of the left lobe. So post hepatectomy, the patient won't be decompensated. So this is post right portal vein embolization. This is the future liver remnant over here, and that has become 73%. And this is the future liver over here. Coming to TARE. So again, TARE is transarterial radioembolization. So the funda between TACE and TARE is TACE produces ischemia, infarction. TARE causes cell death by radiation-induced cell death. Okay. The difference between the two is TACE causes a bit of more post-embolization syndrome, and decompensation can happen in TACE. And what more? If the patient is, if his Child-Pugh score or he's decompensated slightly liver-wise, so you can subject him to TARE. Okay. So this is so it comes in 2 vials. It's called yttrium 90. These are very small particles. We directly inject them into the tumor. Okay. And they come in these vials. There are 2 companies called as Cersphere and TheraSphere which produce them. Okay. So indications. So hepatocellular carcinoma, cholangiocarcinoma, NET, melanoma, breast metastasis. Because treating the liver progressions free survival, it increases the overall survival of the patient. So historically, it was being used as a palliative lobar therapy, but recently in 2023, this year only, it's included in the BCLC classification. That is the Barcelona Clinic of Liver Cancer Imaging. That is the holy grail of what is followed for liver transplant, hepatectomies. Okay. So it's been included in that now. So historically, it was being used as a palliative lobar therapy just to debulk the lesion. But now it has been used to facilitate hypertrophy of the future liver remnant. It's been used as a bridge to transplant to downstage the lesion and as a definite curative intent. So this is a DSA image. It includes, there's a pre-procedure and a procedure. So pre-procedure, we have to evaluate few things. So what we do is on table, we have to see how much shunting is there from the liver to the lung, because we don't want this radiation particle to enter the lung because it will cause radiation-induced pulmonary fibrosis. So we inject something called as a technetium MA. MA is microalbumin aggregate. So what we do, this is a fluoroscopy image. We selectively cannulated the right common hepatic artery. This is the lesion blush over here. And we injected MA. Then the patient is subjected to a gamma camera, and we calculate the shunt. So shunt should be less than 10. And I'm sorry. And in the same while, we calculate the volume about how much this pre-planning basically we do for calculating the amount of radiation dose which has to be given to the patient. Okay, so yeah, so here again, over here we have blocked the right gastric artery because we don't want it to reflux in the right gastric artery and go inside the stomach, because it will cause radiation-induced gastritis, ulcers, basically radiation-induced ulcers. And this is a post-PET after injecting the uh, uh, yttrium 90. This is the distribution what is seen, and this is one example. At presentation after 1 month of tear, and you can see there is good fibrosis and all. A good necrosis seen over here. So this is tear. So coming to bland embolization. So this was on my first month in July when I joined Jupiter. So this was referred. So this is a 23-year-old female, incidentally detected with multiple renal masses. And on evaluation, she had multiple renal angiomyolipomas. So she had a very big one in the lower pole of the left kidney. It was almost 15 centimeter, and around one 5.9 centimeter, 5.6 centimeter lesion in the upper pole. So she was subjected for nephron sparing surgery for the left lower pole, and the upper pole lesion, we just embolized it because that is the treatment. If it is more than 5 centimeter, there is a chance it can bleed. So to avoid that, we did a So basically, yes. So I went in, we did a cool. So nothing, we went in, we selectively cannulated this lesion. This is the artery supplying the lesion, and we just embolized it. And eventually on follow-up, when the patient came back, so this was around 5.6 centimeter reduced to 4.2 centimeter. So there is no level 1 evidence to it, but whatever retrospective analysis has been done, if the lesion is less than 5 centimeters, then the chances of bleeding is less. Then coming to GI bleeds, upper GI bleeds and lower GI bleeds. Normally, signs and symptoms are hematemesis, a positive Ryle's tube aspirate. Okay, and indication is normally, as it should be, the patient is first subjected to endoscopy or colonoscopy. And if we don't find a cause in that, then the patient is subjected or referred to intervention radiology. So this again a case. So this was a 45-year-old gentleman, known case of adeno-CA pancreas, post 6 months of chemotherapy, probably going for immunotherapy. He presented with hematemesis. So initial endoscopy was done, and as you can see over here, there is a large lesion in the head and neck of the pancreas. Head and neck of the pancreas involving the fourth part of duodenum over here at the duodenal jejunal junction. So endoscopy revealed a lot of clots, but no active extravasation. So then I was referred. We did a CT scan, and as you can see over here, the lesion is involving the jejunal branches of the SMA. Sorry, I don't have better images. And yes. So yeah, so we didn't see any active bleeding in the CT scan as well. So this is an angiography of this is the celiac artery, this is the common hepatic artery, and normally the bleeders will be from the gastroduodenal artery over here. The gastroduodenal artery over here. So we did all this, we didn't find any bleeder. Then we took a SMA run. So we did an angiography, and as you can see, there is an aneurysm over here, which is arising from the arising from the jejunal branch of the superior mesenteric artery. So nothing, we went in and we coiled that aneurysm. So yeah, the patient came out of it and he got discharged from our hospital actually. I don't have a follow-up after this. So this is just a retrospective CT scan. So the aneurysm was over here, but pre-procedure CT scan didn't show anything because at the time of that, it might have been clotted. And when I was taking the consent and when the patient agreed to it and he told, I want to go to the restroom before that, I think when he strained, I think the clot got dislodged and he had severe hematemesis and we had to intubate him on then and there. So again, this is one more 45-year-old gentleman presented with hematemesis. Upper endoscopy revealed multiple ulcerative lesions in the stomach over here and enhancing lesion in the first part of duodenum over here. So they were pretty big ulcers. As you can see, clipping has been done over here. These radiodense markers over here. So clipping has been done for these lesions. And CT also reveals multiple lesions in the liver. This one. So the multiple enhancing liver lesions. So this patient was he presented with the, so post clipping also the patient had a positive RT bleed and there was a drop in hemoglobin. He was on vasopressors. So he was subjected for this. So initially when I did a gram, I didn't see anything. I just blocked the gastroduodenal artery. And as soon as I blocked the gastroduodenal artery, the tumor started stealing blood. And as you can see, there is a small aneurysm arising from the right gastric artery over here. So this was cannulated and this one. This is the aneurysm over here, as you can see. And this was cannulated and we blocked that artery. So yeah, and then we did a biopsy and this came out to be grade 1 NET actually. Patient was in a really bad state. Grade 1 NET has a very good prognosis. So with the appropriate treatment, he came out of it, his discharge now. Yes, he underwent PRRT treatment. So coming to endovascular intervention for vascular stenosis. So this is a 35-year-old male presented with severe abdominal pain with excessive sweating. Clinically, he had tenderness, guarding, D-dimers was raised and lactates were elevated. On doing a CT scan, there was an acute thrombosis. This is a sagittal CT scan contrast. As you can see over here, there's a thrombus in the superior mesenteric artery over here, as well as over here. You can't see the jejunal and the ileal branches getting opacified over here. So this patient, this is an angiogram image. As you can see, I'm injecting the contrast, but nothing is, neither it is filling the jejunal or the ileal branches or the ileocolic branches. Then nothing, I went in and I did some plasty. I injected some altiplase. I did some angioplasty, and eventually some clot came out. So this was a very fibrin-rich clot, and post this also the run wasn't very satisfactory. Only the initial part of the artery was getting filled up. So we did a overnight catheter-directed thrombolysis. We kept him on an altiplase infusion, and so that artery actually opened up actually. You can see it over here. So this is the main branch. The left side of the left side branches are getting filled actually, but the right ones, the ileocolic, are still not getting filled. So, but yeah, then in view of fever, tachycardia, and tenderness, diagnostic laparoscopy was done after 36 hours, which revealed some congestion of the small bowel loop, jejunum, and a few edematous and dusky patches in the terminal and the proximal ileum. So he was not subjected to any surgery. So yeah, so post procedure, the image over here is the opening of the main superior mesenteric artery trunk, and these are the ileal and jejunal branches which weren't opacified, which weren't seen pre-procedure. This is a pre and post-procedure comparison. This is pre-procedure, and this is post-procedure over here. So yeah, then finally this patient stayed with us for almost 4 weeks, and then he went home, and then he was well actually, but whenever he had to take he couldn't take a lot of food actually. Whenever he took a lot of food, he had severe abdominal pain, and then eventually he came back and he developed a few strictures and perforation, and he got finally operated for it. That was almost after 2 months of this. So basically, the good thing is he didn't undergo a lot of ischemia, or because he would have lost his whole of his. I believe, I don't know, but he might have been subjected to a ileal transplant or a small bowel transplant if this artery wouldn't have been open. So yeah, but he was a pilot, I think, but I don't think so he can pursue it anymore, I believe. So yeah, so this is transjugular liver biopsy. Whenever there is an ascites, uncorrectable coagulopathy, the patient can be subjected for a transjugular liver biopsy. You take a IJV axis, you enter the hepatic vein, and you take course out of the liver. Yeah. So yeah, that's it. There's more actually, but I thought I should stop because it's too much. Yeah. Any questions you want to ask? Thank you.
So thanks, Neeraj. That was really wonderful. I would request all our audience who are on Zoom to post any questions in case they have any for any presentation. We'll be checking the chat box. So my first topic was justifying the risk, but I thought I'll keep it for subsequent meetings. So I'll speak on dysphagia. So dysphagia is difficulty in swallowing. So these are some terms. So dysphagia is difficulty in swallowing, as simple as that. Odonophagia is painful swallowing, when there is pain while swallowing. Regurgitation is different than vomiting. Regurgitation, you effortlessly bring out all the esophageal and gastric contents. So vomiting is different. You get an aura before that. You know that you are going to vomit. Regurgitation is just effortless. So these are important terms. I like this cartoon, so I wanted to keep it. I've written the diagnosis on every case so that we save time. So the important thing is to get a history when you are seeing a patient of dysphagia. So she's a 27-year-old unmarried girl, daughter of a farmer. So she came to us with intermittent dysphagia for many years. This is important. And she needed to eat slowly, that's all. And it was more for solids and liquids. There was no weight loss, there was no GI bleed. Fortunately, some wise doctor had done barium swallow for her. And that had shown esophageal web. Can you all see this? Oh, it is not seen here. How do I show that? Pointer? I have. This. So this is the web. So many times you are not fortunate enough to know that patients have web. So while doing endoscopy, sometimes you are doing under local anesthesia, it is difficult for patient to swallow, but then you can see the web. This is how the web is seen. This is seen as a thin transparent membrane just beyond the UES, upper esophageal sphincter. So they are called post-cricoid webs. So the treatments are generally, sometimes you can give anesthesia and then try and slightly push the scope. So you can dilate this web with the scope only. But the best part to do will be a Savary-Gillard, that's a Muji dilation. Most of the times patients do respond, they don't come back, there is no recurrence of the symptoms. So that's the easiest thing you can do. There is something called Plummer-Wilson syndrome, in case the medicine residents would know. So you have an esophageal web and anemia, most likely because of poor nutrition that they have. It's not exactly pre-malignant unless you have xerosis on the hands. So they are known to have a precursor of esophageal malignancy in future. So web is something where you will do barium swallow first when anybody comes with dysphagia. That's an advantage. Second is a case of pilisophagitis, not very uncommon. She was a lady who was diabetic. She was 52-year-old, and she had 1 week of progressive dysphagia. So this is very important. All the students should remember. So she also had chest pain while swallowing, and the difficulty was for solids and liquids equally. So this is short history. So you should ask for any prior event. So she had history of taking doxycycline injection for some infection. So when you have chest pain and sudden onset dysphagia, both for solids and liquids with some history, you should think of esophageal injury, which can be a chemical injury. So this was the endoscopy that showed, you can see this ulcer. It's a superficial ulcer. It's a well demarcated ulcer. It's a small ulcer. There is no mass. So it almost fits into the diagnosis of pill esophagitis. It is generally common in people who have some underlying dysmotility, or people are taking medicine and they're sleeping immediately. They're not taking adequate water. So the pill goes and sits there. So generally this with big pills. So this lesion was biopsied and it just showed acute ulcer. There were no inclusions. So we kept symptomatic treatment and she improved. Generally, you don't go and check back again, repeat endoscopy. So certain medicines which are known to give, doxycycline is a main culprit. Other common medicines are ibuprofen and alendronate. So you have to give instruction to the patient that they have to dissolve, they have to take water, they should not lie down immediately, especially elderly, diabetics, reflux patients who have dysmotility. So this is very important. Coming to third case, Candida esophagitis. Many of the audiences also must have seen this because it's fairly common entity. This was a 67-year-old man who was diabetic and who was on chemotherapy. And he came with HB drop and difficulty in swallowing. He also had odynophagia. The oral examination itself showed oral thrush. You get similar lesions in the oral cavity. So the diagnosis is pretty simple. It is oral as well as esophageal candidiasis. You may not sometimes do a biopsy to prove if the findings are they are quite pathognomonic. So, but we still did gastroscopy because he had dysphagia to rule out any other pathology. So gastroscopy also showed these white lesions. They are quite typically a curdy white precipitating lesions in the esophageal mucosa. We did biopsy, it showed candidal hyphae. We treated him with fluconazole. So that's a nice cartoon I found. So this is esophageal candidiasis. The high risk patients are immunocompromised patients. In today's era, they would be post solid organ transplant patients on immunosuppressants, any other immunomodifying agents, then patients with HIV or AIDS, patients on chemotherapy, and patients who have hematological malignancies or other abnormalities. So somebody who has poor immune system. The common symptoms are retrosomnal chest pain, odynophagia, dysphagia. And this is how you can see the oral thrush, which I just spoke about. The treatments are generally they respond well to fluconazole. We just have to take care of liver biochemistry. But in case you have invasive candidiasis, then sometimes you may need posaconazole or voriconazole, micafungin, and advanced drugs. So there are other causes or other infections which you will see in immunocompromised individuals. This was very common when we had patients in the COVID era and post-COVID. So this is cytomegalovirus esophagitis, large ulcers. You may not see the inclusions, but you will have to do CMV titers in blood. Herpetic esophagitis, people who are on common immunosuppressants can also have it. It's very painful swallowing. Esophageal tuberculosis, not primary tuberculosis. Generally, they are mediastinal lymph nodes which burst into the esophagus. You can still aspirate some contents. You can send this biopsy for gene export. You can see primary esophageal tuberculosis, but it's very rare. The treatment is essentially the same. Now, coming to another common interesting cause of dysphagia, which all should keep in mind, including the radiologist, is achalasia cardia. It's a motor cause for dysphagia. She is a 67-year-old lady who actually just got operated last month. She came with intermittent dysphagia for more than 20 years. So again, long-standing dysphagia, which was intermittent, not giving any other symptoms. Solids equal to liquids, chest discomfort and back pain and regurgitation, bland regurgitation. Whatever you eat, it will come out. So these are clues on history that you are dealing with achalasia. So gastroscopy showed dilated esophagus. So this is a very huge esophagus, and this is stale food. In fact, few patients who have long-standing dysphagia, when we know that it is achalasia, we keep them fasting. We put rice tube, we give esophageal washes, and then do the endoscopy. So that is equally important. You must rule out a secondary achalasia, that is anything blocking the LES, lower esophageal sphincter. So a good examination of lower esophageal sphincter, the retroversion, the cardia examination is necessary, because sometimes CA cardia, which is only on the gastric side, can also come as secondary, can come as achalasia. Another thing that you need to do is barium. Most of the surgeons would do it just to see the morphology of esophagus, whether it is sigmoid esophagus and how bad is it dilated. And esophageal manometry, this is sort of a graphic record of esophageal movement. I have not got a picture of that. It shows characteristic features such as high lower esophageal sphincter pressure, failure to relax, and aperistaltic segment. Um, we don't know exact cause of achalasia, but it is thought that it is it's a triggered in some genetically predisposed individuals. So maybe it's some viral infection, and the susceptible population you would find that there is inflammation at the lower end, and there is loss of inhibitory neurons, and there will be insufficient LES relaxation, and they would come with achalasia. So these is like aganglionosis, something like that. So you fail to dilate. So people, whatever they eat is with gravity. So many of them learn to do maneuvers. They sit straight, they elevate their shoulders. So that's why they keep on going for a long time. So you will not see them wasted, malnourished, because they learn to adopt to change their nutrition. So you may diagnose it very late. So they don't come because it's a congenital anomaly, but you will never see them in children. So you will diagnose it only in the second or third decade. So maybe 10 years back, the treatment of achalasia was balloon dilatation or laparoscopic Hehler's myotomy. You need to cut the muscle. There is no medicine that will work on them. But of late, because of manometry, you have different types. We can't go in details. Now the treatment is tailored according to the type of achalasia. So type 2 will respond to any treatment that you have in mind, pneumatic dilatation or surgery or laparoscopic Hehler's myotomy. But in type 3, probably POEM will do better because you require longer myotomy. And most of the patients would definitely respond to myotomy, the Hehler's myotomy, the standard gold standard treatment. In higher risk individuals, where old patients, they have comorbidities or they are poor risk for surgery, you can still resort to what is called as botulinum toxin injection. So you inject this toxin at LES endoscopically, and you can see fairly decent response for a period of a year or so. Subsequently, the effect starts fading off and you can repeat these injections. You can also have non-achalasia dysmotilities in the esophagus. The commonest would be a reflux GERD. So this patient also got operated a couple of months back. She had dysphagia which was intermittent, especially to dry food. She had heartburn, volume reflux was 5 to 6 years, and the dysphagia generally sets in later when the esophageal dysmotility sets in. So this is an endoscopy picture. You would see that these are esophageal folds which show some irregularity. These are specific endoscopic classification of reflux disease. She was treated with double dose PPI. But because the symptoms were significant and she had volume reflux, we had advised manometry, the pressures were low, and she was advised fundoplication. So that's a complete treatment for that. You have to rule out that there is no esophageal dysmotility before you do surgery. There are other causes of dysmotility also. Patients with diabetes, hypothyroidism can also have esophageal dysmotility. People with systemic sclerosis can also have difficulty in swallowing. You have primary esophageal dysmotility disorders also, like nutcracker esophagus or hypertensive ileus. Last is esophageal cancer. This is the only diagnosis which everybody is looking for when you deal with patient of dysphagia. So she's a 79-year-old unfortunate lady. She had progressive dysphagia, which is almost near total. She came to us with cough for a week. She was very weak and she had lost weight. We did an endoscopy. It showed this mass. This is almost lumen-occluding mass. She was not able to swallow saliva also. And by that time, she had aspirated. She had poor vocal cord movement also. So her histology, we do a frozen section. We have an instant pathology which showed squamous cell CA. So even a small caliber scope, a pediatric gastroscope also could not be passed. So we had tough time in treating her. The CT scan showed long esophageal growth. There was also suspicion of tracheoesophageal fistula. She had liver metastasis. It was very difficult. So we had asked oncosurgeon to have their opinion. The chest physicians were called and anesthetists were called to give her the best treatment. And she was poised for anything, any treatment that you would offer. Finally, the family agreed for self-expandable metal stent. I hope this runs. This
arrow keep this right now.
which one?
Right arrow key.
is showing next. Okay, so this is how the growth looked, very tight, ulcerated. Somehow we could get the guide wire across. We can see this guide wire going into the stomach. So this was very tight. We had to dilate with Savary dilators. We began from 5, 7, 9, 11. Then we passed a pediatric scope. We saw the extent. You can see this stent now. Can you see? This is the stent. So you can see it slowly opening. And this is how the stent looked. So now finally she's sitting up with good saturation of around 96, 97. And this is how the contrast is going flowing freely. So these are last 2 slides. So sometimes you're not able to make out that there is dysphagia. I recall a patient who was 62-year-old who came with intermittent dysphagia, but he had become dysphonic and he had started sort of having nasal regurgitation when he was eating. So he was actually myasthenic. So this is how they come. So these are subtle symptoms with which you can pick up somebody having dysphagia. So one is straightforward difficulty in swallowing. Some patients can just have coughing and they start getting choked when they're swallowing or drinking something. Then there will be weight loss because they're just eating slowly. Elderly people, they have cricopharyngeal bar. They eat very slowly. Or sometimes cervical osteophytes can compress the esophagus from behind and they will just eat slowly. You may not do anything for that, but they will come with dysphagia. Frequent chest infection because they have been slowly aspirating. They may just come with lung abscess or aspiration bilateral pneumonia. Food felt in the mouth or it remains in the throat. There is something called as Junker's diverticulum. There is a diverticulum right up above the esophagus. I mean, near the upper esophageal sphincter. So they will come with dysphagia, elderly people. And people take long time to eat or drink. So just at history, if you ask just more questions, it's not very difficult to know what you're dealing with. So if people complain of difficulty to begin swallowing, that they can't even initiate the act of swallowing, this is a neurological dysphagia because the muscles are not working. They will aspirate, they will have low voice at the end of conversation, and they will have other neurological complaints like motor neuron disease or Parkinson's or bulbar palsy, something like that. There will be painful or odonophagia, painful difficulty, short history. Something is wrong, there's a chemical injury or a foreign body or a corrosive ingestion or some infection. Duration is of utmost importance. Something which is lasting for a long time is unlikely to be malignant. Intermittent progressive, something is changed. Somebody who has reflux disease now comes with dysphagia, you are probably dealing with peptic stricture. Solids more than liquid, it's a mechanical dysphagia. Liquids as well as solids is a motor dysphagia. Chest pain and regurgitation would mark towards achalasia. Change of voice, weight loss, cough would make you suspicious of malignancy. So this is a small chart as to how you can localize the source of dysphagia. So whether it is supraesophageal or whether it is esophageal. So this is quite good actually. So if there are symptoms of aspiration, nasopharyngeal aspiration, dysphonia, abnormal neurological examination, then you think of supraesophageal. You get a neurologist to evaluate your patient. Also get an ENT referral. I remember actually Yogita just left. She had a patient with, it was a glossopharyngeal nerve. So he had a very painful pain in the neck and dysphagia. So it was some kind of vasculitis. So this is what we discuss: ALS, amyotrophic lateral sclerosis, Parkinson, myasthenia, pseudobulbar palsy. They will also come with dysphagia. They may come walking to you. Then esophageal dysphagia will be essentially mechanical and motor dysphagia. Mechanical will be benign and malignant. So all rings and webs, peptic strictures, and malignancy, which can be because of either squamous cells or adenoceae or cysts, leiomyomas, big polyps. All these things are possible. Whereas inflammatory will be anything. Most common is reflux, eosinophilic esophagitis. People do see sometimes. Caustic injuries, pill esophagitis, scleroderma. This we already discussed, metabolic causes, and some primary motor diseases of esophagus. So history and basic evaluation, basic investigations you can come to a definitive conclusion of dysphagia and pretty easy to treat. Thank you. If there are no questions, I'll invite Dr. Pinky. She is director of our laparoscopy division. So she'll be speaking to us on day-to-day common topic. I hand over to Dr. Pinky.
Thank you, Mukta. We'll
My title is, my general, be specific. Basically, the reason was today's generation, there's a lot of super speciality. So we have forgotten our basic, and general surgery is actually considered as the mother of all surgeries. Yeah. So general means chief. So actually general surgery is the chief of all other specialties, super specialties. So whichever branch we take in future, but basic principles don't change. And the commonest problems with any specialty patients come is perianal problems. So that's why Dr. Parijat Gupta had requested to take about perianal cases, the problems. So that's why this topic is on perianal. And the aim is that the complaints, though they are general, but the diagnosis should be specific. All PR bleed is not piles in common terminologies. And all patients of constipation is only not to be given laxatives. We have to find the cause of constipation. So the symptoms are common like painful defecation or PR bleed or constipation, but the cause has to be individualized and then only treatment should be prescribed. And over the counter or on the phone, patients who are known to us, we give them medicines on the phone as doctors. This is absolutely wrong and that leads to delay in diagnosis and disaster. So I'll present few short cases. Just to give you an overview how things can be disastrous. A 66-year-old female, known case of diabetes, complained of pain and swelling at perineal region, unable to sit, decreased appetite since 4 days. After 4 days, she came to the OPD. She was sitting outside. This is during COVID times, and she developed perspiration and shivering. So she was immediately shifted by the nurse outside in the OPD cluster to the casualty. BP was 80/60. She was in complete septic shock. She gave history of constipation 10 years ago, and I had seen her 10 years ago when I had told her no surgery required because she had only come for constipation. There were some skin tags. So I told her skin tags does not require excision. So she took that statement of mine 10 years ago and she said कि it was only constipation since 4 days, so I did not visit you. This was the statement. So when I examined her, she had a bad horseshoe-shaped pituitary abscesses. The CT scan was done, which showed large area of inflammation and gangrenous changes involving rectal wall also, and extending up to supralevator extension. So obviously this patient needed urgent drainage, but since the rectum was properly involved in the bilateral icterate abscess, she required a diverting colostomy. If you drain only the abscess, she could not settle because there would become continuous fistula. And after 3 months, we closed the colostomy. So the essence of presentation of this short case was that we should not miss any perianal symptoms. Any patient who has perianal problems, they many times give them medications on phone, which is wrong. Inability to sit is a symptom of abscess. Many times that is a symptom of an abscess. And continuous pain, if patient complains of continuous pain, again it's a symptom of something throbbing the whole day. It cannot be only transient. And shivering, fever, patient may not have high-grade fever, just shivering. That itself is suggestive of a small abscess or a large abscess. Inability to evacuate is a very important symptom in all perianal cases. So these things should not be missed out. Second case is I had seen this patient 30 years ago, 19-year-old male who complained of perianal pain and discomfort with occasional PR bleed. On examination, he was diagnosed to have fissure in anum by the resident doctor. This was in a public hospital. He again visited the resident doctor 2 months ago, 1 month in follow-up. I'm not feeling fine. The senior registrar saw, the lecturer saw, the boss saw, and was diagnosed as fissure in anum, and the anal dilatation was done. Patient kept on coming to the OPD, and again one resident then again saw. And after 4 or 5 months of frequent visits to the OPD, one of the resident did a proper PR examination. I mean, proper means the whole finger has to go inside properly. And it was adenocarcinoma of rectum. So because it was 19-year-old boy, everybody thought it's a fissure in ano, and then they kept on, in simple public hospital terms, batting. The patient was being batted from one unit to other unit and one OPD to the other OPD, and he had recurrent symptoms. Follow-up is very mandatory in all perianal cases. Even if we have not been able to diagnose what the condition is, tell the patient to come and show in 10-15 days time, because then you can pick up again, you can re-examine and think in different manner. Many times patients who have a subsphincteric abscess or nothing is present on PR, there's a small bulge. These are the patients who actually have a small abscess which is there's no fissure. So they have a throbbing pain. So you can diagnose it after review examination. So fixed mindset has to be changed that young patients cannot have malignancy. That has to be changed. That's the reason why in Bailey and Love it is mentioned, if you don't put your finger in it, you'll put your foot into it. This patient, it was advanced malignancy by the time it was diagnosed. He already had a
अगर
spread to the
पहले
bone. He
जरूरत पड़े तो
underwent
सिलिकॉन वाला इस्तेमाल
neoadjuvant and then
करना या फिर
APR.
ऐसा
He
जिसका टिप
required abdominoperineal
0.5 mm से
resection.
मोटा हो
That 19-year-old
और अपने
boy.
पास कोई कैंची मत रखना
So
ताकि
45-year-old
मरीज को
male,
या खुद को
another
उससे
patient
नुकसान ना
who
पहुंचे
presented to
समझे?
a tertiary referral center in Mumbai and was a casualty for some 8 to 9 hours. When he was diagnosed, he was told that he has some
हमारे यहाँ पर्दे
peritonitis.
तक
He needs
नहीं।
exploratory laparotomy.
हमारी
Unfortunately,
सुबह
casualty was
किसी
very
भी
busy that day in
दूसरे
that
वॉर से
hospital.
पहले शुरू हो
So
जाती है।
he got furious and he drove away with his driver. He went to Pune. He got operated in Pune. The notes mention exploratory laparotomy done. 2 liters of pus drained. No cause found. No perforation. Bowel intact. Patient was stabilized. He went home. He developed incisional hernia. Mesh plastic was done within 3 months of the primary surgery by the same center. And later on, he came to us after 1 year of surgery with a non-healing sinus over anterior abdominal wall and pus discharge through perianal area, which was not sure. Hence, patient consulted that time. So, clinical history was very classical. When the patient has got a perianal discomfort and a primary peritonitis, the cause can be ruptured ischiatal abscess, which has gone higher and caused
इनसे मेरा ये
peritonitis.
है,
So this patient was
Cancer
having
की
a
nerve
primary
jump down,
fistula from the
internal
beginning.
medicine से आई
So
है।
on PR,
आप सबको मिलकर अच्छा लगा।
the internal opening was felt right at
तुमने
6 o'clock
यहाँ
position
अपनी
within
internship
2
की थी
finger,
ना?
within 2 centimeter from
हाँ,
the inner
यहाँ
verge.
इंटरनल
He
मेडिसिन
had,
से
I
तो
don't
काम
have the
नहीं
images
होता
of
तो
this
गलतियाँ हो
patient.
सकती
This
हैं।
was in
तुम सब लोग
2015 we had
इसकी
done.
मदद
He
करना
had a long
प्लीज।
fistula right from perineal area
और सबसे
to
पहले तुम हेड
suprapubic
नर्स
area.
पार्क सुयोन
So
के
we did
साथ
a
काम
fistulectomy
करोगी।
and removed the entire tract, and then his abdominal wall thing also healed. So Dr. Pankaj Joshi is here. He has many such interesting cases of fistula and eno where patients have come with multiple fistulas externally. Up to thigh also patients have had external
ये
openings.
वो रूम है जहाँ हम
Thigh,
अक्सर
groin,
पेशेंट से बात
buttocks.
करते हैं।
Sometimes there's a water can perineum, multiple openings.
चाहिए।
So fistula and eno should not be
पेशेंट्स गुस्से में
undertreated.
आकर
They
दरवाजा
need
ब्लॉक कर देते हैं,
therapy.
तब हमें निकलने
There are
का
many
रास्ता
advanced
मिलना
therapies
चाहिए।
also now. I'm not going into treatment modalities of
ये
fistula and
बाकी
eno,
वार्ड्स की
but
तरह
all
ही
these
है,
patients
सिर्फ
do
कुछ
require
सुविधाएं
surgical
अलग हैं।
remedies. So intermittent discharge from perineal area
तो ये
is a
हमारा
diagnosis
therapy
of fistula. Discharge may be purulent, may be bloody or serosanguinous, and patients will complain that now I'm fine, but 20 days ago or 2 months ago I had a boil. That is again a diagnostic marker of fistula. They have a boil which ruptures, their pain subsides. Once the discharge is there, pain subsides. Then it keeps on discharging, they don't bother.
तुम्हें टेबल
Then again after 1 month, 2 months or 3 months, again the boil, the external opening closes, so they have pain. So they ignore it, they think it's a boil. It's a heat boil. Okay.
ओह, तुम काफी तेज हो।
These are the classical
जल्दी
symptoms
समझती
of
हो।
fistula and
इतने
eno.
सारे प्रिस्क्रिप्शंस जो आते हैं।
Last case is 64-year-old female.
यहाँ
This
कैसा
is
लग रहा है?
recent
पता
history.
नहीं आज पहला
Actually,
है तुम्हें।
unfortunately, she was a doctor's mother only,
हाँ।
but
क्या मैं पूछ
they
सकती हूँ, तुम्हें
underwent a
fat
stapler
actually क्यों चुना?
hemorrhoidectomy 5 weeks ago at a
सब
peripheral
जानना
center.
चाहते हैं।
And she had PR bleeding on and off, pain at inner area and loose stools, multiple
मुझे
episodes.
लगता
The
है
history was
मिस जुंग के
she
साथ
had
कुछ बुरा हुआ
had
है।
loose motions for few days,
तुम
few
दोनों
months,
कॉलेज में
3 to
दोस्त
4
थे,
months.
पूछा उससे?
She visited the primary surgeon who had operated
जो भी
stapler
वजह थी,
hemorrhoidectomy. The
बताने में
again
झिझक रही थी।
post-op patient comes with pains. We try to conserve it. So as a natural course of events, he gave conservative therapy. Patient did not settle. After 5 weeks, she presented here because past
ये
history में I had done her
थी।
parathyroid
जी, मैं
surgery
समझ
some
गई।
3 years ago. So she visited here. She gave, when I inquired, she gave history of altered bowel habits since 4 months. She had loose motions on and off. She had pallor. And this was a clinical picture. Extremely painful condition. Large external hemorrhoids. So without doing a PR, because PR is painful in such conditions. So I just advise her admit, then we will see. So advised admission, antibiotics, analgesics, IV fluids, and I asked for a CT scan because the history was of loose motions last 3-4 months.
तुमसे मिलकर खुशी हुई।
She did not have any loss of appetite, loss of weight, but she was looking little pale. HB was 7.5.
चामिंसो।
This was a CT scan. You can see here a mass in the
मैं
sigmoid.
जंग डाउन हूँ।
और ये है
मैं
So
आएंगे
we did a
हूँ।
PET scan. PET scan showed sigmoid mass and also a
जल्दी
breast
वेलकम पार्टी
mass.
करते हैं।
जी
So she had double malignancy. And any elderly patients who come with PR bleed, even if we
चलो,
find
इतना
external
मुश्किल
hemorrhoids, internal hemorrhoids, we
पहली
should
बार
not jump for
outpatient treatment कर
surgery.
रहे हैं।
They need a
सारे patients को अपने
sigmoidoscopy
पास
or a
भेजने के लिए
colonoscopic
कहा।
evaluation to rule out
अरे वाह,
malignancy
क्या
higher.
बात है।
Because this is a fresh onset of symptom. It's not a symptom which is going on for
अरे क्या
years.
हुआ तुम्हें?
So this patient underwent the colonoscopy showed differentiated adenocarcinoma sigmoid and IDC in the breast. She also had liver parenchymal disease diagnosed in CT scan. She underwent large sigmoid colectomy with MRM in the same sitting, and she's doing well now, currently on chemotherapy.
ठीक है।
So the essence of presenting these 4 cases was that one should be not taking the perineal symptoms lightly, and every PR bleed is not piles. So painless PR bleeding is hemorrhoids bleeding. Tenesmus, if it is present, look for any rectal ulcer, ask for a history of digital evacuation, ask for rapid recent onset of change in bowel habits. That's a very important thing. And preoperative colonoscopy, as I said, it's always mandatory. Patients may not give proper history. We have to actually ask direct questions. So we have to actually probe and take out the history. Many times they shy out or they don't open up for the perineal problems. They don't speak. So we have to actually ask them all the history properly. So back to basics now. Painful defecation is fissure or anal spasm, perianal hematoma. It's an acutely painful condition, especially occurs following any travel, or ischiorectal abscess, perianal abscess. Painful PR bleed is again fissure. Drops of blood will flow. Patient will not give history of splash of blood. A painless PR bleed is usually hemorrhoids, soiling clothes. Elderly patient who comes that, pajama gilla ho gaya, dhoti gilli ho gayi. They will say like that I got up, I saw blood on the floor. So that is typical painless PR bleed is hemorrhoids. Tenesmus, altered bowel habits, or mucus in stools, suspect carcinoma rectum, or solitary rectal ulcer, especially if patient has a history of digital evacuation. Something coming on per rectum and patient says, many times they say that there's external hemorrhoids. So all external hemorrhoids do not require surgical excision, do not require treatment. One has to go with the internal hemorrhoids if there is there and patient is symptomatic, then surgery is required. Swelling with pus discharge, it's perineal abscess or fistula. Now, one important thing here, when a patient comes with history of occasional blood in stools, fresh blood and bloody stools going on since few months or few days, and on PR you don't find anything. Do not forget to do a proper proctoscopy. You can find proctitis. These are the patients of ulcerative colitis. So many a times we have picked up ulcerative colitis based only on proctoscopy without colonoscopy. So you can easily diagnose ulcerative colitis on proctoscopy. And then we refer for colonoscopy. So I think at least 8-10 patients we have diagnosed like that of ulcerative colitis only based on this finding. They do not, when you ask the history, then they say, yeah, the bowel habits, they think that 4 to 5 motions per day is normal for them because that's going on since few months, few years. But if the frequency is there, and they will not say that stools are bloody, you have to actually ask them. So ulcerative colitis is one thing which can be picked up by simple proctoscopy. So this is the classical picture of fissure in ano. It's basically a linear cut or a ulcer or a tear in the inner area because of straining factors, because of passage of hard stools. That's the clinical picture, how it looks like. Treatment is symptomatic. We give local pain relief ointments like lidocaine jelly, anti-inflammatory medications, and sometimes if pain is severe, inflammation is severe, oral antibiotics also work. This is as per the guidelines of colorectal surgeons. If the patient has recurrent fissure, then 2 to 3 weeks of sometimes doxycycline, low dose antibiotics, Ceftriaxone, or local ointments help. Indication for surgery is acute unbearable pain, not responding to medical therapy, severe anal spasm. These patients, one should not keep on giving medications. And severe spasm, presence of hypertrophic papilla. If on PR we find both anal polyps, papilla, these patients will never respond to medical therapy. They will give a partial relief, but not a complete relief. So that indicates that the scarring is already there, so they require surgery. So treatment for hemorrhoids is again grade 1 and grade 2 lifestyle modification, avoid spinning, add laxative, bulk laxatives. And sometimes this Ayurvedic medicine called Sitcom, Euphoria, I'll give the name properly later on, that helps. Indication for surgery is painless, large hemorrhoids bleeding, and constant discomfort due to something coming on per rectum, severe itching. Sometimes only itching is an indication for surgery. They have severe defecation, irritability and itching. So perianal hematoma, this is a classical picture, sudden onset bulge, recent prolonged travel may be there, or a recent straining factor may be there. In these cases, give painkillers, antibiotic, local ointments, they settle. If they don't settle, if they have severe pain, bursting hematoma, then a small lick is required to drain the hematoma. So some surgeons always feel that the hematoma should not be conserved at all, should be operated immediately, but many times I've seen few of them have been conserved. They don't require eventual surgery. So local applications, just not marketing any trade name, but whatever commonly we use, just mention. The Sitcom is Euphorbia prostata extract, which helps in decondition the hemorrhoids. So that is given for 14 days. Similar name ointment is there. And if patient has severe spasm, then one should give nifedipine and lidocaine combination ointment. But these ointments, if you are giving, tell the patient not to get up immediately. Lie down for 10-15 minutes and then get up. Otherwise, they may have giddiness. Especially in elderly people, avoid giving nifedipine if they are already on antihypertensive medications. And Metrogyl and povidone combination is required if patient has a wound
तो
in the
आपका
inner
अगली
area.
एडमिशन हुआ है
Hydrohil
हाँ,
gel
अपनी
is
मर्जी
again
से है।
amorphous
तो अपनी
hydrohil
मर्जी
gel
से
for
यहाँ से
wounds,
जा भी
perineal
सकती हूँ,
wounds
है ना?
later on.
आप खुद
And
एडमिट नहीं वहीं बस एडमिट
Saludam
होके
cream if
मान
patient
गई
has got
इसका मतलब
rashes,
ये
loose
नहीं है
motions,
कि
diaper
आपको ऐसे
rashes,
ही
then
डिस्चार्ज
Haldon
मिल
cream
जाएगा
helps.
अगर डॉक्टर ने कहा
So
आपको ट्रीटमेंट
precautions in
और सुरक्षा की
multidisciplinary
जरूरत है और
patients
आपके
is if
गार्डियन ने
patient has got
अनुमति दे
fever,
दी तो आपको प्रोटेक्टिव
dengue
एडमिशन
fever or viral
में
fever
लिया
patient is
जाएगा और आपका यहाँ
admitted.
से
These
निकलना
patients
मुश्किल होगा
eventually because of high grade analgesics, antibiotics, they
मतलब
go
है
into
आपका?
anal spasm, they have severe painful defecation.
इस
So
consent
many
form
a
पर
time
sign कर
patients
दीजिए।
come
मैंने
3
sign
days
कर
post
दिया था।
discharge from
बस
the
ओरिना को
hospital
discharge होना
for
है,
fever
तो हम
and they have a
उन्हें
fissure.
protective admission
So
में
when
ले
we
रहे
are admitting the patients for fever
कानूनी
and we
तौर
are
पर
giving so
इसके
many
लिए 2 guardians
medications,
के
we should
sign
ask the
लगेंगे।
bowel habits
उनकी
also
शादी हो चुकी
and
है
give a
तो
cover
उनके
the
पति का
treatment
sign भी
protocol
चलेगा।
with a laxative. That is helpful.
दरअसल
Post-operative patients,
मेरे
cardiac
दामाद
patients,
जज हैं।
CABG,
वो
orthopedic
बहुत
cases,
busy
all are
रहते हैं।
elderly, neuro
मुझे नहीं
cases.
लगता वो आ
These
पाएंगे।
patients also in the
72
prescription,
घंटे हैं।
a laxative
sign करने
is
का time मिल
mandatory
जाएगा।
because
क्योंकि
otherwise
अगर
they'll
sign
end up
नहीं
with
मिला तो
problems.
मिस ओ को हम discharge कर
Onco
देंगे।
patients. In onco patients, what happens if they have
ये
severe
आप
constipation, they
protective
form a
admission
perineal
का है।
abscess, and already they are on chemotherapy.
ओह
The wounds don't heal, and they create a lot of disaster and nuisance. So hence, all onco patients also should be covered with laxatives. Constipation can be cause of bacteremia. So because of location of bacteria, gram-negative bacteremia can occur. Hence, all these patients who are on fever or medical onco, they
Ma'am,
should be supplemented
आपको
with
हमें सच
laxatives.
बताना होगा।
So dietary
क्या
recommendations
आपके
for all
दामाद ने
perineal
ये
cases
sign
are
किए हैं?
common. Increase the fiber in the
मैं
diet,
झूठ
increase
क्यों
the water
बोलूंगी?
intake. Stool
अभी आके
softeners
sign
are
किया है उन्होंने।
supplemented
सवाल
and
आपकी
bulk
बेटी के
laxatives
हक
if
का है
patient
तो
has got
पूछना
frequency
जरूरी
of
है
motions.
उन्होंने ही साइन किया।
So Dr. Vireshi helped me
अगर हम
making
उन्हें
this
फोन करें
presentation
तो आपको
and
एतराज
thank
तो
you
नहीं
all
होगा।
for patiently
इस
listening.
फॉर्म को भरने में पूरे 2 मिनट लगेंगे। वो बहुत बिजी रहते हैं, उन्हें फोन नहीं कर सकते। आई एम सॉरी, पर आपके
Chat box
दामाद
also
को
there are no
यहाँ पर
questions.
आकर ही
So
साइन
we move
करने
on to
होंगे।
the
मिस जंग
जी
जब ये फॉर्म लेकर वापस आए तो मुझे दिखा देना।
जी मिस सुम
ओके।
Patient's name, chat box also. I now invite Dr. Ravish Ravindan. He's a consultant rheumatologist with us. He will speak about Mythbusters.
रीना को दे देंगी
Ravish?
प्लीज।
आई एम सॉरी पर मुझे पहले से चेक करना होगा खाने की चीजें अंदर अलाउड नहीं है
ये अंगूर हैं, मेरी बेटी को पसंद है।
अच्छा
मेरी बेटी एक जज की बीवी है, स्कूल में हमेशा क्लास प्रेसिडेंट रही, अच्छे कॉलेज में भी गई। उसके बारे में बात करती हूँ तो लोग जलते हैं उससे। ऐसी जगह नहीं होना चाहिए उसे।
मैम आप वो फॉर्म कब तक ला सकती हैं
There's a question in the chat box. A young patient with chronic constipation needs digital evacuation, no PR bleed, or relief with laxatives. Should we give laxatives continuously? I think if the patient is young, we can supplement with laxative, but lifelong laxatives, natural laxatives like isabgol powder or liquid paraffin or castor oil, sabza, these will be helpful. So also they should be trained to improve the diet. If the diet is not improved, only supplemental laxatives may not help in the long run. They will get resistant to laxatives.
मुझे नहीं लगता ऐसा हो पाएगा आपकी माँ आपको लेकर बहुत परेशान है
ऐसा तुम्हें लगता है?
So after high energy talks where people are putting
ये सब बस
catheters,
दिखावा है।
scopes and finger,
मुझे
I
यहाँ
think
आने
I
की असली
can
वजह जानना
calm things
चाहती
down
हूँ।
a bit.
असली वजह
So my talk is about Mythbusters. Basically, we are trying to bust
सच
some
कहूँ
myth.
तो
I hope all of you must have seen this program. Started off
किसी से
in
बहुत प्यार करती हूँ।
quite some time back, and almost
और
8
वो मेरा
successful
पति नहीं
seasons.
है।
I hope I can bust some myth
बल्कि
and
वो
make
कोई
it as
और
interesting
इंसान
as
है।
they did. So
क्या?
the first question would be asymptomatic hyperuricemia, do we treat? So how many of you agree whether do we treat asymptomatic hyperuricemia? Okay. So the answer is no. Okay. Because hyperuricemia itself is not a disease.
तुम्हारी वजह
Treatment
से
should be
नहीं, okay?
restricted to only
सच कहो
specific
तुमने मेरे लिए ट्रांसफर
circumstances.
लिया है क्या?
Patients about to
सच
receive
कह रही हूँ,
chemotherapy
नहीं
or
लिया।
radiation therapy that is likely to cause an
तो फिर
extensive
साइकियाट्री यूनिट में
sepsis.
क्यों आई हो?
Patients with history of
मुझे
kidney
तुम्हें
stones who are
वजह
at
बताने
risk
की
for
जरूरत
recurrent
नहीं है।
uric acid
अगर मेरी वजह
nephrolithiasis.
से नहीं है तो
Patient with background history of gouty attacks,
अरे, एक
tophi,
मिनट, एक
or
मिनट।
moderate renal
मिस
function
ओलिना तुम्हारी
impairment
पेशेंट है
can
ना?
be
क्या
considered
लगता है तुम्हें?
which can be considered high
उन्होंने
risk of
खुद कहा
chronic
है
gouty
कि उसकी माँ उसे
arthritis.
जबरदस्ती
Or
यहाँ
unless
लेकर
the
आई है,
uric
वरना
acid
वो
is at
बिल्कुल ठीक है।
12 or 13 in men or 10 in females.
ओलिना ने
So
कहा,
basically we
उसे
see a
किसी
lot
और
of
से
patients
प्यार
being
है,
treated
अपने पति से
with
नहीं। उसका
uricosuric
affair
drugs.
चल रहा है
including
उनकी history
females
लेते वक्त ऐसा कुछ नहीं
with
कहा होगा।
uric
एक बार
acid
फिर
of
से चेक
borderline
करके देखो ना
7.2, 7.3, 7.4 with some basic joint pains, which could have been very mechanical in
बकवास नहीं
nature
है।
or, just
वैसे वो अपने
myofascial
पति से
pain.
नहीं किसी और से प्यार
So
करती है।
we should restrict the use of
रीना ने आपको
uricosuric drugs for any particular
इसके
kind
बारे
of
में
therapy
बताया?
unless and until you have these indications and if the patient doesn't have any specific
देखिए
symptoms
मिस
of a
ओ का कहना
gouty
है कि आप उन्हें
attack
यहाँ
or a
पर
gouty
जबरदस्ती लेकर आई
arthritis.
हैं ताकि वो अपने
So that is
दर्द से
one
दूर
thing
रह
we need
सकें।
to be very, very
नहीं,
careful
ऐसा
about.
कुछ भी नहीं है।
क्या आपके दामाद
Do
को
we need
पता
to
है
stop
कि मिस ओ इस वक्त
non-vegetarian
हॉस्पिटल
diet
में
or
एडमिट
protein
है?
diet in Indian patients with gout? So once you are
शायद
diagnosed
आप
with
उनसे सारी बातें
hyperuricemia
छुपा
and you
रहे
have
हैं
some big
और
joint
इसलिए आप
complaints,
कंसेंट फॉर्म पर
your
साइन नहीं करा
tur
पा
dal
रहे
is gone, your spinach is gone,
ये
your
देखिए,
non-vegetarian diet is gone, everything is out of the window and people are really, really frustrated, what to eat, क्या खाएं तो क्या खाएं, दाल बंद कर दिया, non-veg नहीं खा
उसके
सकते.
खिलाफ रेस्टोरेंट
So
कर
I
रहे हैं।
feel that, it
रीना
is not
दरअसल
required.
उस लड़के का पीछा
Our
कर
why?
रही है।
Because the Indian protein consumption
क्या
is much lower than 48
आप
grams
कहना
per
चाहती
day
हैं कि
that is
मिस ओ
recommended by
उनके
the
पीछे पड़ी है?
ICMR.
और जज
The recommended
इसके बारे में
dietary
कुछ भी
allowance
नहीं
for
पता।
protein for an
मेरी
average
बेटी
Indian
पागल
adult is
हो गई
around
है और किसी
0.8 to 1
दूसरे आदमी
gram
के
per
पीछे पड़ी
kg
है।
body weight.
ये
However,
बात
the
मैं
average
कैसे
intake
बताऊं?
is about 0.6 gram per body weight. A 2017 survey showed around 73% of Indians are deficient in proteins, while about 90% are unaware of the daily requirement of proteins. So in general, we take very
पहले
less
मुझे आपका
proteins,
ब्लड प्रेशर चेक
and the
करना है।
people who
देखिए,
claim to
मेरा
be
यकीन
non-vegetarian
कीजिए, मैं आपसे कह
are
रही हूँ
also
ना,
taking maybe
अब
once
मेरी
or twice
तबीयत
a
बिल्कुल
week,
ठीक है।
and
मुझे
even
अपने
once or twice
बॉयफ्रेंड
a
से
week
मिलना
also
है।
is usually a
वो
small,
बेचारा
very,
परेशान
very
हो रहा
small
होगा कि मैं
quantity.
यूँ
So
अचानक गायब कैसे हो गए?
depriving somebody of a high
देखिए,
protein diet, maybe it
दरअसल
may be
बात ये है
vegetarian
कि
sources
आपकी
or
माँ
non-vegetarian
ने
sources.
क्यों? अब क्या कहा मेरी माँ ने
From the
आपसे
Indian
मुझसे?
point of view, we need not. So whatever textbooks have been
बताइए
written are
मुझे।
usually written by
वो
Europeans
कह
and
रही है कि
Americans. Their
आपको
diet is
कोई
totally
गलत
different.
फहमी
They eat
हुई
bacon
है।
and beans in the
ये तो
morning. They
सिर्फ
have
एक
steak.
क्रश
They
है।
have a lot of seafood.
क्या?
They have a lot of alcohol.
एक
So
क्रश?
that doesn't really
क्या
translate
मतलब
to
क्रश है?
the diet that we take. We are
माँ ने तुम
mostly a
लोगों का भी
carb-rich
brainwash
diet.
किया?
Idlis and dosas and
ताकि मुझे
pohas.
यहीं रखो?
So we are not taking too
मैं
much of
sorry।
non-vegetarian or a high protein diet.
मेरे
So
बॉयफ्रेंड को अभी के
restricting
अभी यहाँ लाओ।
high protein or normal protein diet also may not be recommended. So please do not advise unless and until the patient is a very hardcore non-vegetarian who takes everyday non-vegetarian diet. Survey around 16 cities in India on a perception of knowledge and consumption of protein. We found gap in the knowledge and quality of proteins in daily diet. Various myths surrounding the protein consumption, with 85% believing leads to weight gain. So they think that if I eat non-vegetarian diet or dal and all those things, I'll have more of weight gain. Global protein consumption is on the rise, average around 68 grams per person per day. India has the lowest average consumption, around 47 grams per person per day. Generally, in females, the overall protein consumption is generally less, means tend to take more proteins as compared to females.
मुझे
So
बताओ।
restricting protein
मैं तुम्हारे लिए कुछ भी
or a non-vegetarian diet, it may not be necessary for the Indian to non-vegetarian diet. I don't take frequent non-vegetarian diet. I tell them not to take the second serving. Okay, अच्छा लगा और एक लेके. So if you can do that, if you can restrict or
तुम्हारा
moderate
पति जज
your
है, घर में
consumption
नौकर
of
चाकर है। तुम्हें
diet,
गाली
protein-rich diet,
तुम्हारी माँ ने
I think it should be
दिलाई।
okay.
अपनी माँ
You
से
can
मदद
continue
मांगो।
having the normal diet
कितनी लगी?
तुम्हें कभी कोई कमी नहीं होगी। तुम्हारे पास
in
सब
spite
कुछ
of
है।
having hyperuricemia. It's a very Indian context. Gout is common in both
बहुत
sexes. I
अकेली
can
रहती
see
हो आजकल?
rampant
कुछ
use of
हुआ है क्या?
uricosuric drugs
पागल
in
हो
both
गई हो
females
क्या?
and males.
तुम मुझे सब कुछ बता सकती
Who
हो।
thinks that it is
जो भी
common
हो,
both
मैं
same
सुन
in
लूंगा।
both sexes?
अपने पति और
Or is it
बच्चों
more
को
in males
बस ऐसे ही
versus
छोड़
females?
दूंगी।
ठीक है, कोई बात. So the overall incidence in a
रीना मेरी
menstruating
अच्छी
female is
बच्ची, तुम ऐसा
extremely
क्यों कर
low.
रही हो?
Okay, so people who are menstruating, ladies who are menstruating have very, very low chances of having hyperuricemia or hyperuricemia related gouty arthritis. So patients who have a borderline hyperuricemia or borderline reports 6.9, the value is 7, and the patient has some joint complaint, the patient is put on Feburic or allopurinol or something like that. So you have to refrain yourself from adding any kind of drugs because the chances are very less. It could be something else which is probably causing the pain, not the uric acid. Okay, just because it came borderline, you don't need to start. So as postmenopausal, the chances go high because the estrogen levels in the body go down. Estrogen per se has uricosuric effects. So females have less hyperuricemia than males, possibly due to high estrogen levels in the premenopausal females, which promotes the uric acid excretion by inhibition of renal urate reabsorption by the organic ion transporter. So estrogen reduces the uric acid in the blood, and by improving the excretion. So another myth, obviously the uric acid thing is done now, and we'll go to the common question that whether rheumatoid factor and anti-CCP changes with therapy, because a lot of physicians, a lot of GPs repeat the rheumatoid factor after 3 months or 6 months to see whether it is actually benefited, whether his treatment is benefited or my treatment is getting benefited. The patient sometimes खुद से भी कर लेता है. Okay, after 3 months he repeats the rheumatoid factor and anti-CCP because initial factor was around 500 anti-CCP. Patient comes to say अभी भी 500 है, क्या करें? आपका दवा से कुछ फर्क नहीं पड़ा है, but the patient is walking, jumping around, doing everything, but the rheumatoid factor and the CCP is not coming down, or if it is coming down, not adequately coming down. So generally, it doesn't correlate with the disease activity. It may fall. So titers may fall with effective treatment in patients who are originally rheumatoid factor positive. The fluctuation in the level of rheumatoid factor and ACPA does not correlate with the disease activity. It doesn't mean that as the disease goes down, your ACPA or the RF factor will come down. So rheumatoid factor and ACPA should not be routinely used to monitor disease activity in a patient in clinical practice. So basically you have to look at the CRP levels that can give us a baseline idea of how the inflammation is going on, and obviously the clinical parameters, the examination, and how the patient is faring over a period of time. Your patient themselves would tell that how early morning stiffness is there or not, whether she is able to carry out all her daily routine activities. So basically quality of health and inflammatory markers like CRP. ANA positivity always indicate an autoimmune disease. Is that true or false? True. Do you think that anybody who has an ANA can have? Healthy individuals from 20 to 60 years of age, ANA was detected in 32 and 5% of the sera in dilutions of 1:40 and 1:60. So almost 32% at 1:40 and around 5% at 1:60 in normal healthy individuals. Okay, so ANA positivity doesn't mean that the patient has an autoimmune disease. ANA when detected in dilutions of 1:40, it's the value in that study specifically. So what you should understand is the international consensus is that only if the ANA is more than 1:60 should be considered as positive. Anything 2 plus, 3 plus, I just want to clarify, simplify it. So if it's 2 plus or more with a specific pattern, or 3 plus, 4 plus with a specific pattern. Sometimes you get all these lot of 1:160, 2 plus mixed pattern, or cytoplasmic, homogeneous, nucleolar. So these are usually non-specific patterns. If you have a speckled 2 plus or a homogeneous 3 plus or a nucleolar 4 plus or 2 plus, 3 plus, those are specific patterns, and usually they are pathological. Okay. So you need to be very, very aware of the ANA patterns also. So ANA testing, a lot of other diseases can have ANA positivity. So it is lupus is obviously the commonest. Scleroderma can have, rheumatoid itself can have, Sjogren's can have, MCTD, drug-induced, polymyositis, dermatomyositis, and juvenile idiopathic arthritis. All of them can have ANA positive state. That doesn't mean that only lupus or any other specific autoimmune disease. Patients with autoimmune rheumatic diseases cannot become pregnant. There are a lot of patients who come to us who have been advised not to get pregnant once you are diagnosed with autoimmune diseases. That is not the case in today's times. With the amount of expertise that we have, the kind of medications that we have, patients can undergo successful pregnancy. The chances of successful pregnancy is very, very high. The live birth rate of patients with lupus is high and attributable to good disease control and patient care during pregnancy. Pregnancy complications were low and mainly associated with chronic hypertension and APLA. So if you carefully monitor the patient and take care of the patient's parameters and guide them accordingly depending upon what kind of drugs can be used. So there are certain drugs as per the ACR recommendations which are safe during pregnancy, and there are certain drugs which have to be avoided. So those recommendations need to be followed, and usually the patients can have a successful pregnancy. The only condition would be that they would have to have a regular checkup. They would have to have ideally a tertiary care center where you have multidisciplinary team available who understand the disease and who have expertise with dealing with autoimmune diseases and pregnancy. So it is always better to have an institutional based pregnancy or delivery for patients with autoimmune disorders. Methotrexate causes interstitial lung disease, always a problem.
और बहुत सारे केसेस में
So
hallucinations
it
या
doesn't.
delusions
Okay,
भी हो
so
सकते
many
हैं.
a times
मैं
patients come back to me
कुछ
after 3-4
दवाइयां
years
prescribe
or
करके
sometimes
हमें
lost to follow up.
मैंने
सर
भी
हमारे
सुनी थी,
डॉक्टर ने
फाइल
बोला
में
आपका
पढ़ा, वो बहुत
फोलिट्रेक्स की
अमीर
वजह
घर
से
से
हमारा
उनकी
लंग
परवरिश
खराब हो गया.
आलीशान थी.
Okay,
फिर
तो आपकी
उन्हें
दवा से
बीमारी
खराब हो गया. It's
कैसे
like
हो
an
गई?
accusation,
अमीर
right?
होने का ये
So
मतलब तो
we
नहीं
try.
होता ना
It's
कि
very
mental health
difficult to
problems नहीं होंगी. सोचो, हर
explain
गरीब
that
की ये problem होती है.
methotrexate doesn't because
नहीं,
they've been
मैंने
fed
ऐसा नहीं
through
कहा.
many
हो सकता है
places
मिस
that
पो को भी
this is the
सब लोग
cause
ऐसा ही
that
कहते होंगे जब वो
you've had
बीमार
this
होती
problem
होंगी.
and this is why the lungs
तुम्हारे
have
पास
got
तो सब
damaged.
कुछ है, तुम बीमार क्यों
So
हो?
there is enough evidence to show
लोग
that
psychiatric unit
methotrexate
तब
and
आते हैं
rheumatoid
जब उनकी
arthritis,
mental
especially
immunity
lung
कम हो.
disease,
जैसे जब
methotrexate
हड्डी
is
टूट जाए
not
तो
per
हम
se
orthopedic
the
के पास जाते
cause
हैं.
for any kind
मतलब
of
ये
lung
कि
disease.
ये
Autoimmune
किसी को भी हो
diseases
सकता है.
inherently have a chance of having interstitial lung disease.
चलो अब मैं
So it's not the
तुमसे कुछ
methotrexate
पूछता
per
हूँ.
se which is causing, it is the natural
तुम यहाँ
evolution of the
psychiatry
disease
unit आई
which
क्यों?
might have caused the interstitial lung disease.
तुम्हें लगा मेरे यहाँ वैसी चीजें
Methotrexate,
आसान
through a
होंगी?
lot of studies have
नहीं.
been noted
हाँ.
that it per se may
वैसे
not
तुम
be an
ऐसे हो नहीं.
effective treatment for ILD. That's why probably
तो
when
मुझे
even if
पसंद तो नहीं
you are on
करने लगे.
methotrexate, your
क्या
joints are
पागल हो
getting
क्या?
control, the
तो फिर
lungs may
यहाँ आने
get
की
worse
वजह क्या है?
over a period of time.
इंटरनल
So
मेडिसिन की हेड नर्स ने कहा
uh,
कि मेरे लिए साइकाइट्री
there are a
सही
lot of
रहेगा.
studies saying the
बस
same
यही
thing.
वजह.
Basically, you can this
उसने
chart
कहा
will
और
show
तुमने मान
that
भी लिया.
तो क्या
there
गलत
is
किया?
a
वो मेरा
rheumatoid
भला ही
arthritis
सोचेंगे
patient
इसलिए
where the
मैंने उनकी
patient
बात
is
मान ली.
has
तुम
no
मेरी बात
respiratory
क्यों मानती?
symptoms.
हाँ?
Over a
तो
period of
इसलिए
time, when
क्योंकि
the
तुम मेरी
duration of
बिल्कुल भी
methotrexate
इज्जत
goes
नहीं
higher
करते.
and the
जितनी
patient
दिखते हो
respiratory
उतनी बुद्धू
symptoms
हो.
comes, and that is when
खैर,
we meet a
किसी को बोलना मत कि तुम मुझे
pulmonologist
जानती हो.
and
क्योंकि
or
अगर
of
सबको
chest
पता चला कि
physician or
मैंने
a
सिखाया
physician
है,
maybe.
हाँ? और
They
फिर
tell
अगर
that
तुम
it is
गलती
because
करोगे
of
तो
your
सबको लगेगा कि
long-standing
मैंने तुम्हें गलत
methotrexate.
सिखाया है.
So you can
नहीं, मेरा
see
impression
that
down हो
the
जाएगा.
evolution of the disease per se from the lung point of view has been
Obviously,
gradual
हो
over
गया.
a period of time. It's not the drug which is per se causing. So there are a lot of there are no comparative studies saying that patients who were not on methotrexate, what is the natural progression of
Bipolar disorder
ILD
होगा.
in RA or autoimmune
Manic
disease
state लग
without
रहा है,
any
डॉक्टर के
specific
पास जाना
therapy,
चाहिए.
because that kind of a study becomes difficult because without treating you can't compare. Okay, or if you can't just let the patient not be treated. Okay, so there is a growing body of evidence to refute the role of methotrexate in fibrotic ILD. But in a patient with a pre-existing lung disease, we should recommend an assessment of respiratory reserve before starting methotrexate, because the patient has a lung problem. You should not start methotrexate, or if you want to start methotrexate, make sure that you have a proper detailed thorough investigation about the lung capacity. Why? Because to determine whether the patient could cope with a potential decompensation, which is rare event in a rare event of a pneumonitis occurrence secondary to methotrexate. Methotrexate induced pneumonitis is a hypersensitivity reaction. Patients can have lung involvement secondary to methotrexate, but is not fibrotic lung disease or ILD. Okay, it's an idiosyncratic reaction. But if a patient is already having a lung problem, make sure that you evaluate and then decide. So preferably the ACR has come up with newer recommendations in 2023, where a conditional recommendation for use of mycophenolate, rituximab, cyclophosphamide, and azathioprine as the first line ILD therapy or treatment options. The conditional recommendation against the use of leflunomide, methotrexate, TNF-alpha inhibitors, abatacept as a first line. So you need not start off if you know that the patient is having ILD. Preferably don't start with methotrexate, because you have better options available. You've got rituximab, you've got azathioprine, you've got mycophenolate. So they have a conditional recommendation against using methotrexate as a first line ILD. So that first line is very important. It doesn't say that you don't use methotrexate. Okay, so that's it. I think that's the
तुम पागल तो नहीं हो ना? अच्छा, काम का पहला दिन कैसा था?
क्या कहूँ?
Trying to keep it light,
Patient
after
की मार
very.
खाई मैंने.
Sorry?
क्या?
Methotrexate is very good with lot
देखो,
of
तुम
other
फट्टू
things
मत बनो,
which a
ठीक है?
patient can present with autoimmune disease
Psychiatry
like
unit में
arthritis,
transfer
which is
लेने
a
का
very
idea ही
common
बुरा था.
presentation.
मैंने
It is
सोचा
very good
वहाँ
with
की head nurse मेरा
vasculitis.
भला ही
Okay, so
चाहेगी,
these are
इसलिए
the
मैंने
two
उनकी
major
बात
problems
मानी,
which the patient
लेकिन
comes to us
ऐसे
with.
किसी
They
की भी
don't
सलाह
directly
पर
come to us with an
ट्रांसफर ले लेना
ILD.
बिना
ILD may
सोचे
be very
समझे
subtle
सही है
initially,
क्या?
तो ये
but a
ट्रांसफर
dominant
लेने से
complaint
पहले
in an
सोचना
RA would
चाहिए
be
था ना?
joints.
अभी भी देर नहीं
So
हुई है,
joints
चाहो तो फिर से
would
ट्रांसफर
very
ले लो.
good, has very good response to
ले लो?
methotrexate.
बस
So that is
अब
the
चुप करो.
methotrexate is a primary drug for many
हे
autoimmune
जनता,
diseases.
हाँ
So there's a
तुम्हें
question. You can
बिना
read the
दर्द की
question
मार
and
कैसे
answer.
खाते हैं सिखाऊं?
क्या ऐसा नहीं होता?
होता है, पता है ना, मैं बॉक्सिंग करता था।
The question is, can high protein,
पंच मारना
carb
जरूरी था,
restricted
पर बिना
diet
डरे पंच लेना असली टैलेंट
cause increase in allergies and loose
जब
motions?
थप्पड़ अपनी तरफ
So
आता है,
it is very,
तो
very
उसकी उल्टी
subjective.
दिशा में अपना
It doesn't
मुंह
mean
फेरना,
that just because you're taking a high protein,
जिससे
low
तुम्हें
carb
ज्यादा
diet,
दर्द
you
नहीं
get
होगा।
loose motions.
हाँ,
Some
हाँ,
people
उल्टी
may
दिशा
have
में
some
मुंह फेर लो।
problems with
चलो,
certain food
ट्राई
items,
करते
which is
हैं
probably
एक
high
साथ।
in
एक साथ।
proteins.
हाँ,
Some
फोकस
people
करो।
cannot
तैयार
digest
रहो।
very high concentrated
3,
proteins that may
2,
cause loose motions.
1
So it is
तो बताओ,
not saying that you
नहीं लगी
should
ना?
restrict your protein intake. Obviously, if you can't
लगी
tolerate a
तो।
certain amount, because
लगी?
sometimes the patient go very high on
हाँ
proteins.
तुम्हें
Okay,
दर्द
they
हुआ?
take protein
हाँ
supplements and they start eating eggs and
शायद
everything, which
तुमने
is
ठीक
not
से
the
मुंह
usual
नहीं फेरा।
routine. Sometimes it
चलो
can
चलो,
cause some
फिर
GI
से एक बार ट्राई
upsets,
करते हैं,
but
ठीक है?
otherwise,
फिर से। 3,
regular
फोकस,
protein-rich
2,
diet as per the
1
dietary recommendation and a low-carb diet
ये
to
हुई
keep
ना
your
बात,
weight down
अब
will
दर्द हुआ?
definitely
नहीं
help
हुआ
you in
होगा
the
ना?
long run in coming out of
हुआ ना,
these kind of
बहुत
disorders.
दर्द हुआ।
दर्द तो नहीं होना चाहिए।
तुम्हारी बारी, अब मैं थप्पड़ मारूंगी।